So thank you for having us to this year's competition. We are excited to share our ideas with you today. And so without further ado, we'd like to present Communication, a Model Approach by Krista S.K., Sarah Marshall, Spencer Bilhoviak, and myself, Rebecca Payne. So I'm going to briefly go over what we're going to talk about today. First, we're going to meet Lynette. Then we're going to go over both her and South Tree Health Network's root cause analysis. I'll go over our new approach to healthcare, go over outcomes assessment, cost analysis, and then summarize before answering any questions you may have. So let's meet Lynette. Lynette's a 53-year-old female. She was born in Ginkgo Grove, lived most of her life in Kentucky. She also identifies that she values hard work, independence, and most of all her family. We also identified that she greatly mistrusts the healthcare system. So let's go over her root cause analysis. So Lynette had a stroke, or a CVA. We're going to use these interchangeably. Why did she have a stroke? She had several uncontrolled risk factors, including hypertension, hyperlipidemia, type 2 diabetes, that went undiagnosed. So why was this? She had no preventative health care. There was never identified at any point in her life whenever she had a primary health care provider, made regular visits to the doctor, none of that. So why did she have no preventative health care? She didn't have access to health care. She identified that spending $300 a month on her family was better spent than her own health care. So this is a big problem. And lastly, we identified culture, whether that's the culture of her mistrust in the healthcare system, which we already identified, or the culture of prioritizing her family over her own health with the $300 a month that she would have spent on her health care. So let's go over South Tree Health Network's root cause analysis. First, we'd like to commend you on things that you're already doing wonderfully with. You're already providing mobile health care screenings. You're already providing stroke awareness and prevention to the community. However, they're not reaching the people that it needs to reach, such as in Lynette's case. She had no pre-screening for these health risk factors. That wasn't identified. And also, South Tree Health Network, the hospital systems don't share the same EMR. There's different EMRs. And this led to no protocol for missed orders, which also led to insufficient documentation for protocols. Therapy services were then contracted out, which led to no follow-up with home health, and no patient and family education was rendered. So these are all problems. But what's the common problem among all of those? That's communication. So communication. We thought this quote fit your problem best. The single biggest problem with communication is the illusion that it has even taken place, by George Bernard Shaw. So communication, whether it's the lack of communication at the community stage in the prevention of stroke, or whether it's at the organizational level with a hospital where interprofessional communication was lacking. So what is our mission today? Our mission is to decrease stroke for patients in your health network. And we're going to do this by improving the quality of care given in the network. How are we going to do this? As we already identified, we're going to start with improving communication. Once we improve communication, our patient safety will improve. If we improve patient safety, then we're going to have happier, healthier patients and have improved patient outcomes. So once we accomplish all of these things, we think the triple aim will be met. And Sarah will be speaking about this more in depth later, but we're going to have improved health, patient health, we're going to have improved patient experience, and we're going to have decreased healthcare costs. So what's our approach for this? As I've already mentioned several times, we're going to start with improved communication. We're going to emphasize prevention. And so should we approach this from a top down, so from at the top of the network branching down, or from the bottom up approach from the community level going up? And here to talk about that more is Krista.
Thank you, Rebecca. So when considering avenues for affecting change in your healthcare system, interventions to improve communication can be made at the top of the pyramid, which contains a ratio of relatively few individuals who impact the greatest number of people, such as your healthcare network. These are great because these organizations are typically the farthest removed from the culture of the community. However, they stand to affect the greatest impact on that community based on their ability to integrate all of these other levels. Changes at this level would be what we're considering our top-down approach. Making changes at the highest level of the organization would allow for impacts all the way down the chain. Changes may be made at the next level of the pyramid, at the workplace. And changes at this level have a greater deal of interaction with the community members. However, and with this, they're more in tune with the needs of those individuals. However, they can only affect change on a smaller scale compared to that of a health network. Local organizations are even more ingrained with the community members. Yet again, changes at this level sacrifice the sweeping impact on the larger population. Lastly, changes may be made at the level of the community. Changes at this level are more immediately felt and directly affect individuals and their specific needs. And interventions at this level would be what we consider to take a bottom-up approach, where the change would come from the individuals rather than from the organization. We believe that no single approach is best and that we need to assess this issue from a global perspective. We would like to use a multi-tiered approach in which you, as a health network, will act as an integrator for all of the other levels. All of this will result in our goal of improving the quality of care for each individual patient. So, at the level of the healthcare network, we propose the implementation of a Medicare Shared Savings Accountable Care organization in order to improve communication and quality of care within your health network. We know you've considered this in the past, and we would like to prove to you why this is now a worthwhile endeavor that will create a high-performance delivery system of healthcare. Our improvements that we would like to see included are a system-wide electronic health record system in order to prevent mistakes and duplicate services, as well as further integration of rehab professionals into your networked health system. All of this will lead to improved health outcomes for your patients. At the level of the workplace, we would propose to use the good components of your current program and improve upon them. You're already offering community-based screenings to increase the health care of the individuals in the community, and we propose that you simply expand upon these screenings in order to increase your level of impact. We also propose that you work with insurers to provide reduced premiums for workers if they receive those screenings or improve upon their lab values within a year. All of this will lead to increased utilization of preventative health services, cost savings for employees, and healthier employees as well. At the level of the local organizations, we suggest your support in developing a student-run free health clinic for low-income individuals that could be staffed by health students from your local universities. A retrospective study of a student-run free clinic project at UC San Diego by Smith et al. In 2013 found that students can provide quality medical care. In this study, diabetic patients receiving treatment showed significant improvements in glycemic control, cholesterol levels, and blood pressure. Furthermore, a study by Seif et al. In 2014 showed a benefit to students as well, with students who participated in a free medical clinic showing improvements in interprofessional perceptions and attitudes, as well as clinical reasoning skills over a control group, making them great future employees for your region. Outcomes at this level would be that the uninsured and underinsured would have access to high-quality health care. Lastly, at the level of the community, we propose that you develop initiatives for students from local universities and health professionals within your network to go to schools to educate teachers and students on health concerns such as stroke, its warning signs, and healthy lifestyles. This information could then go home with the students so that they could educate their families. This would allow for a transfer of knowledge to the greater community through the educational system rather than through the healthcare system proper, which members of the community may be more likely to trust and have increased access to as well. Now, if we take this multi-tiered approach that we're proposing into consideration with Lynette, if she had access to any of these interventions at any point along the pyramid, she might have been prevented from having a stroke in the first place. At the level of the community, if her children had come home with information about health and warning signs of stroke, she might have known about them a little bit earlier. At the level of the local organization, if she had access to a free health clinic, maybe she would have gone there to receive care. At the level of the workplace, if she had been incentivized to participate in an insurance program, she might have actually received screenings. And at the level of the healthcare network, if there were an integrated network with better communication, there might have been better discharge plans, better home health care, and also an overall better outcome for Lynette as well. And in order to provide a little bit more information about these proposed interventions, I'd like to invite Spencer up.
Thank you, Krista. So as you can see from this picture of Kentucky that represents the medically underserved, There's a complete lack of healthcare professionals in the area of Kentucky. We'd like to eliminate this area in the red, specifically more in Perry County and the surrounding areas. And with your support, you can be an integral part of this. The new model of delivering primary care is patient care that's focused on patient-centered, comprehensive, coordinated, and most importantly, accessible to everyone. There's an emphasis on a team of healthcare professionals working together to provide integrated and comprehensive care to patients. This cohesiveness and team-based approach allows for fluidity of care and vision from all professional viewpoints. This approach helps in driving down healthcare costs and while maximizing patient care. There are currently 152 free clinics in Kentucky, and with your support, you can make it 153. In partnership with the University of Kentucky, you'll open a student-run free medical clinic. The mission is to provide affordable, sustainable healthcare services to the low-income and uninsured patients at 100 to 200% of the federal poverty level, primarily through volunteer services and community support. The clinic will provide services that are not limited to clinical services, as well as nutritional counseling, testing, and labs, and they will be referred to specialists as needed. The clinic can provide ambulatory and chronic care to patients with non-emergent conditions. This clinic will serve as a service-learning, student-driven outreach project that strives to enhance the health and well-being of the community through the provision of medical care. So what are the benefits? The most important is going to be early disease diagnosis, prevention, and management, which is the key to reducing hospital readmissions and admissions for chronic and acute medical care. This site will provide health professional students as well with clinical and multicultural education and experiences. Literature shows that this benefits in the fostering of a learning environment through the preceptors and rotations at the site, assisting and also in the recruitment and retention of needed healthcare professionals in the area. Managing qualified patients in the outpatient settings will decrease length of stay within your hospitals and decrease readmission rates, while also driving down hospital care costs and the cost of health care to the community. As hospitals face decreasing reimbursements and increasing penalties, referral programs with local free clinics can help them control these costs. By allowing emergency department members and also caseworkers to refer free clinic patients for non-emergent conditions will reduce unpaid visits at the hospitals. Statistics show 1 in 5 sick people visit the emergency room for care that they could have received by a primary care provider. Ultimately, this will save hospitals and improve the quality of care of patients. Krista spoke earlier about implementing your EHR. Hospitals usually have information systems that are much more sophisticated than what a free clinic would have. The local hospitals can benefit with the free clinic by data sharing. And by data sharing partnerships, the clinical data will be shared and can help them more effectively and efficiently coordinate care and keep patients out of the hospital when their needs could be better met by a free care clinic. Such efficiencies will be extremely crucial, especially with talking about implementing the ACO, where we see healthcare providers that need to work together collaboratively, and accept collective accountability for the cost and quality of care of a patient population. If hospitals are on the same EHR, it would allow for hospitals to capture all the patient data, including in the hospital and outpatient free clinic, and they can use this as an effective cost analysis. Appendix page 6 and 8 outlines the startup and maintenance costs, along with the necessary individuals of healthcare professionals that are going to be needed to run the clinic. The value of early diagnosis, prevention, and management of chronic disease greatly outweighs any cost to implementation of this. We also want you to think about the impact you can have on educating the community with accessible care and in reaching a patient population that was once uncared for. We think it would also be beneficial for you to use clinical indicators of improvement care. This would allow for the health network to capture patient-specific experiences and overall value of services of the hospitals and clinics that are providing. The EHR would also allow communication amongst individuals, institutions, providers, clinics, and as well as patients through the patient portal. With this information, you will see quality improvement recommendations and concerns that you could eventually lead to reduction in readmission rates, decreased incidences of CVAs in the community, and allow Bluegrass Blue Shield to do quality analysis on your numbers. Patient satisfaction would include patient surveys at all levels of care, and the surveys would also be accessible online. We think the Institute for Healthcare Improvement has created a great outcome measurement tool that we strongly advise you to implement. The measurement tools focus on 3 dimensions, and that's population health, patient experience, and per capita cost. You can see these improvements more in detail on page 10 of the appendix, and to see how it can successfully measure the integration of the triple aim ideology. And to talk more about cost is Rebecca.
Taking a look at the cost of our plan, according to the 2013 National ACO Survey, the average cost for implementation was about $2 million, with a range from $360,000 to $6.7 million. The cost for hiring 10 each full-time physical therapists and occupational therapists would be about $1.5 million annually. Workplace wellness programs would be burdened by the insurer and would cost insurers approximately $70 to $120 per participant. However, according to the CDC, for every $1 spent on these workplace wellness initiatives, $3.27 is saved in healthcare costs. The estimated startup cost for the healthcare clinic is about $25,000, with an annual cost being about $320,000 thereafter. Community speakers offer a huge impact at no cost. To help offset the cost, there are several grants available to help fund the student clinic. There's a list of these grants on page 9. Affecting South Tree Health Network directly, the American Recovery and Reinvestment Act made $19 billion available to help hospitals implement electronic health records. The one-sided risk module minimizes risk as the network is not held accountable for losses. And there is a possibility of a shared savings bonus if you meet or exceed the minimum savings rate. Also, a reduction in readmission rates reduces the risk for penalty for high readmission rates. In fiscal year 2013, Medicare fined 2,225 hospitals for high readmission rates. Employers would also save, paying less in insurance premiums for healthier employees. We anticipate about $15,000 in annual savings after the first 3 years. You can see this on page 4 of the appendix. Insurance companies would save, paying significantly less for preventive services than for post-stroke care. We've detailed these figures on pages 4 and 5. Regarding the health clinic, though a significant investment, the cost would be offset with grants and fundraising. Also, the health clinic would save South Tree Health Network in the long term by preventing stroke in the community and therefore reducing the number of write-offs for stroke care for the underinsured. The Institute for Healthcare Improvement mentions 5 primary concepts to satisfy the triple aim: focus on individuals and families, redesign of primary care services and structures, population health management, cost control platform, and system integration and execution. We believe our ideas meet these 5 concepts by providing high-quality, high-value care to more individuals, reforming communication processes, improving utilization of resources, and consideration of cultural and community values. Our research revealed several ACOs that were successful. They were able to increase patient experiences while decreasing healthcare costs. One example, by Stuhlman et al. In 2014, looked at Independence Blue Cross in Philadelphia, where they insure 2.5 million lives. Results after the first year included half the hospitals decreased their medical costs, 90% had lower readmission rates, with the average reduction being about 16%, and nearly 100% improved patient experiences. In summary, issues stemming from deficits in communication, lack of services, and cultural issues such as mistrust of healthcare systems are addressed through a shared savings ACO with electronic health record and full-time rehab, workplace wellness initiatives incentivizing participation in preventive services and making health insurance more affordable, and a student-run free health clinic addressing the needs of underinsured and creating a culture of team-based healthcare for your next generation of providers. Finally, community speakers to begin healthcare education early and increase community knowledge on stroke prevention. Our outcomes include improved communication and better delivery of services, convenient care for the entire population, and ground-level change to begin chipping away at the cultural barriers to wellness. We hope that we've been able to articulate and demonstrate the need to cooperate and communicate in order to achieve optimal patient outcomes and fulfill our roles as collaborative, client-centered practitioners. Thank you for your time. What questions can we answer for you?
Well, thank you very much for that. I'm sure we do.
I did.
There it is.
You want to start?
Go for that.
I can go first.
Okay.
You had some very interesting and creative interventions at multiple levels where healthcare systems touch people. How would these all fit together? I didn't quite pick that up.
So I think that our concept is that we can have your network act as an integrator at all of these levels, because there are a lot of different components of healthcare that are lacking. And really one of the biggest things that we wanted to hone in on is prevention and how we can incorporate communication in order to improve prevention. And if you're the ones that are leading this ability to communicate, then that really will be a huge impact on the population as a whole. So as a health network, you have the change with the ACO, so moving to that. So that's one area that you can make a change. And then at the level of the workplace, if you're working with insurers, even within your own hospital, in order to provide reduced premiums for those employees, that's at least a start. And you can show other workplace areas how that can really make an impact. Because as a large corporation, that really shows other workplaces that might be a little bit smaller the impact that that can have on healthier employees. And then at the level of the community, where you have maybe some of your own healthcare workers that are going into the schools to educate the students, you're sending people out, you're getting your name out with your hospital, showing that you can really make an impact at the educational level very early on. And then lastly, with the free health clinic, the concept is that you would partner with them. And so you would be supportive of a free health clinic coming into the area that you could work with in order to provide preventative care for individuals that might not be able to come in and receive services due to lack of insurance.
I really like that you identified early that communication was sort of a primary problem in this case, and your interventions address communication. One of the ways you address it is through the unified EHR across our network. And then you've also proposed that we'll be monitoring metrics consistent with the AAA, and some of those are population level metrics that will have to come from stakeholders actually outside of our network. What challenges do you think we'll have, or what concerns do you guys have as consultants bringing this to us with that integration process? How will we get on board these multiple stakeholders, the hospitals, the Department of Health, the providers, so we can get information from, like, per capita cost is going to have to come from a lot of places. What should we be concerned about?
Concern will probably be implementation. Obviously, is going to be where you're going to be concerned the most, is because you're going to have providers that are going to be not so adaptive to that concern, especially with the older providers that are stuck in their ways. They don't want to implement a new EHR because it has cost along with it. So it's going to be a way to talk to them and ensure that it increases patient safety, that there's more of a benefit overall than actually just keeping with their ways, because you actually see the statistics show that there are a lot of older providers that are negligent to not going to improve on this and to actually take in consideration with the EHR. So it's going to be talking to them and educating them on the benefits that overall it will have for the institution as well as the community and the communication of care. And that analysis that you can do with being on the same EHR will allow for the cost analysis to show you the benefits of cost and the decrease in emergency department rates, because you are referring out non-emergent patients. So that's going to show a decreased cost with people that can't afford to pay for the emergency room, and then you're going to have to eat that cost or do a write-off with it. But if you can refer that way, that's going to be a cost benefit to the hospital, which you can show providers. And also they have also incentivized programs right now, especially with Medicare and Medicaid offer incentivized programs with stages. And if you go through these stages of certain things that you have to apply to, they will actually incentivize you to take in a new EHR.
But also on the organizational level, I know that you had asked a question pertaining to that. if we take a look at your entire network, you're covering a large portion of the area of Kentucky's healthcare systems with all of the organizations that are within your network. So yes, it is going to be a struggle with getting everybody on board, but it's going to be a collaborative effort and partnership in reaching out to everybody and getting everybody on board with that communication process.
Mm-hmm. And if you refer to the page 10 of the appendix, it does provide really great information about how to actually implement looking at some of these outcome measures, and provides a great tool that can further assist you in how that would actually be implemented at the level of the hospital.
Two clarifications. One is you recommended a quote Medicare ACO. So you're talking about restricting this to Medicare enrollees, or are you talking about the ACO designed more broadly across multiple insurers, including Medicare?
It would be across multiple insurers. We like the design of the Medicare Shared Savings ACO, so that's the structure that we took, but it would be open.
So it's a model.
Clear.
Mm-hmm.
So
Correct.
Yes.
Yes.
The broad risk participation
Mm-hmm.
step one.
Exactly.
Do you think it stays there? Because we have this goal of moving to 100,000 enrollees.
Mm-hmm.
Do you think that's the model we stick with, say, over a 5-year period?
You can, with the Shared Savings ACO, with the one-sided risk module, if you decided to stick with that model, you would actually have the option of switching to not the Shared Savings, the two-sided risk module, where you would then be responsible for part of the losses, if there were to be losses, but you would have a greater return as well if you decided to go that way, if the plan was working well in the long term.
So if I hear you right, you're saying stick with kind of the risk initially,
Mm-hmm.
mitigate risk by just having upside, but over time, take some downside risk.
Exactly.
Not necessarily move to like the capitation model or the bundling of services.
We looked into bundling of services, and we had a couple of concerns with that. One being getting primary care physicians in the area on board with that model and supportive of the ACO model, should we go that route. And two, we were concerned, as some people are with the bundled payment services, about the quality of care. So we really wanted to keep quality of care as one of our primary focuses. So that's why we decided to stray away from that particular model.
Okay, fair enough. Another clarification is you're suggesting that we standardize on one electronic health record across the plan.
Mm-hmm.
So we've got maybe, as we select what that network will be, we've got some folks we have in place, others that don't.
Mm-hmm.
So we try and encourage them to literally turn off what they have and put on what standardized will be.
Yes.
Yes.
We are, and we believe that we've pointed out some really nice incentives and some benefit that we could show those providers to really get them to sign on to this. And this isn't just a hospital problem. This is a community and cultural problem.
Okay, well,
Right.
again, clarification.
Definitely.
And kind of would have enjoyed hearing, okay, so what difference would it have been for Lynette if what you're recommending is in place? So here we have a case full of all kinds of defects, but there's the family engaged. There's a lot of interesting elements to the Lynette story. So I'm kind of wondering
Here.
if your recommendations had been in place. And what would be the differences in the processes in here? I understand
Right.
the communication piece, but I'm interested
Yeah.
in the process.
Right, definitely. So if we look at this, for example, we can either look at this from all of the different tiers, or we can look at this just from your healthcare network. So would you prefer to hear about all of the different tiers or at the healthcare network in particular? We're happy to discuss either.
What I'm saying is there we go, okay. If these recommendations were in place, what would have been different for Lynette?
So in Lynette's case, if we had educators from your healthcare system or from the local universities who had gone to the school, Lynette had children. Her children might have come home with information, and that information might have been passed on to Lynette. She might have known a little bit about health screenings, warning signs for a stroke. She might have had something that ticked in her brain that said, oh, I fit a lot of these things that my kids are talking about, or, oh, like this diet that I have is maybe not the best one for maintaining health. So at that level, she might have been prevented from having unhealthy lifestyles in the first place. And then at the level of the local organizations, she didn't really access healthcare ever. It was very limited. And so if she had access to a free health clinic, maybe she would have gone there and actually gotten some screenings. So she would have known that she had diabetes if she had gotten to that point. She would have known that she had hyperlipidemia, that she had high cholesterol, and then she would have been more in tune with those warning signs. Maybe would have made a change before she had a stroke in the first place. And then at the level of the workplace, if she had reduced premiums, maybe she would have been incentivized to participate in an insurance program so that she could receive these premiums. And so she wouldn't have had such a high cost if she were to get to the stage where she had a stroke. And then at the level of the healthcare network, if you have an integrated health record system, then maybe you wouldn't have had the problem where when she was transferred from one location to another, there was a missing gap in information from, say, the speech therapist, which led to her pneumonia, which led to higher costs for everyone because she was in the hospital for a much longer period of time. If that communication had actually happened efficiently and everyone were on the same health record system, then maybe she would have been prevented from having such extenuating circumstances with her health care.
There. Okay, feedback time.
John, great presentation. You clearly put a lot of work into it. I appreciate that it seemed well researched. I like that you added, citations to the actual presentation. I think that gives it. It was a nice touch that I think you complimented us first. It's just sort of a tactically nice approach to the presentation before you started describing how we were going to improve. You did a fair amount of detail on the cost analysis in the appendix, but I still felt a gap between the cost, bringing it all together, and the outcomes. So I think that could have been fleshed out a little bit more. But your presentation style was nice. I think you really kind of showed some depth when we asked questions. That was a real strength, too, after the presentation was over. So nice job.
Thank you.
Well, I really liked that you started out with the patient and wove in the patient's family. That's kind of where it all meets the road, right? And again, as Mike brought out, identifying assets before you got into opportunities was very helpful, starting with that. And then you did call out the disaggregation of those assets. So I think it provided a really nice context for us to hear your recommendations. Again, your use of citation and evidence was very strong, and you had a very interesting focus on communication. Very broad, but you began to bring it alive. However, one of the things that I grappled with, very strong appendix. Reading that was very helpful because in the presentation, I thought you made some big conceptual leaps to the improvement conclusions that I didn't follow all the way through. So had that background not been fully laid out, you might have lost me.
Right.
Again, a nice build out of the triple aim and a great job answering questions.
Thank you.
Thank you.
I would ditto what's already been said, and a couple of things that number one is you brought in an educational focus, and that was part of the charge in terms of what was expected of you, and that was good. That whether it's the student engagement, et cetera, I think that was a unique plus that you get there. The root cause analysis, I think, really good in the sense of getting at the issues that the case showed. Would have liked to have seen something like a process map of the idealized process for caring for individuals such as Lynette.
Right.
There's understanding that, if you looked at what happened, all the gaps and missteps, all kinds of stuff, from eating soda and fries and the speech therapy gap and the lack of available PTs, and here she is left at home without the money to pay for her. So, what's going to happen to her?
Right, exactly.
So, it seems to me that in doing all of this, with the root cause analysis, it could and should lead to process mapping of what this ought to be, and then how all your recommendations, the free clinic, et cetera, fit within that. The other point is the reality of trying to get everybody on one EHR in a community it's very costly.
Right.
And I would suggest that a lot of the approaches you tend to see are these regional networks that integrate, so the data gets standardized and gets communicated back into the separate EHRs, but it's standardized. So there are software approaches to doing that.
Right.
You're going to get an awful lot of resistance for someone with an established EHR saying change it. I don't really think that's going to happen. And it's a lot of money and it's a lot of time,
Right.
and I think there's honestly better things to be doing. So I would be looking more at the regional network idea, just in terms of thinking of that. I like the focus on culture, and community values. That was, and grounding communication ultimately there. The communication, how would I say it, focal point served to do a nice job of integrating everything you did. So I enjoyed it very much, and I thank you for it.
Thank you for your
you.
feedback.
Thank you.
We appreciate your time.
Thank you.